Very good. So know that you are being recorded for antiquity. If you have a problem with that, please don't say anything. Again, welcome everyone. We really appreciate your attendance on this webinar. I'm looking forward to learning more about the state of the state here in terms of community benefit and what one of our member states is doing. That sounds like some really promising practices. It's 3 o'clock in the afternoon here in the greater Washington, D.C. area, Arlington, Virginia. We appreciate you calling in here Friday afternoon. For some of you, it's still morning, but appreciate you spending this time with us together today. We will have plenty of time for questions and answers as we go through the webinar. Let me go ahead and talk about what we have before us. First, two announcements, though. We do have, for those of you who are audio only, we do have a webinar link that came in your calendar invitation. So please click on that link and you can follow along the slides live. And there's an evaluation at the end of this webinar. We really look at those carefully, so please take the time to complete that quick survey. We appreciate that. Okay, so today we're going to hear about community benefit. And first we're going to hear from Maggie Carlin here in ASTHO. She is going to present on the survey findings, which are newly completed. So the survey was undertaken with our member states. It's following up on our strategic plan that the CFOs developed to focus on collaboration with the senior deputies on innovative financing and to look for areas in which we could further the state of knowledge in terms of innovative financing. So there was an innovative roundtable that was held in 2015. It was attended by select CFOs and senior deputies. It was held in Atlanta, Georgia, in conjunction with the deputy-to-deputy meeting that was being convened by CDC. And again, there was several proposals came out of that. One was to conduct a survey. So Maggie's going to walk us through the findings from that survey. We appreciate the time and attention all of you took to completing that survey. Then we're going to take a deeper dive into what Maryland is doing in this area. Dr. Howard Haft, we're pleased to announce to agree to join us today to walk us through that from the Maryland Department of Health and Mental Hygiene. And we'll have plenty of time for questions and answers right after Maggie Carlin's presentation on the survey. If you have some quick questions, clarifications, go ahead and ask those then. We'll have time at the end of the survey too for some Q&A. Upcoming, just some quick announcements here. We have a white paper on the subject that will be forthcoming very soon. It's in the final stages of editing and revisions. We have a report that will provide information on the survey findings in a little more depth than Maggie will provide today. And for CFOs on the line, we have an in-person meeting December 8th and 9th here in the Arlington, Virginia area. Look for an invitation coming through on that in the next week. So in addition to CFOs today, we have in attendance senior deputies. The announcement was sent to senior deputies, so we welcome those of you.
The conference has been muted.
Those of you who are attending as senior deputies and state and legislative liaisons as well. So welcome all. Okay, so with that, we're now going to turn to Maggie Carlin, who will present the survey findings. As a research and evaluation analyst, Maggie Carlin supports the implementation, analysis, and reporting of ASTHO surveys on state health agency infrastructure. We have quite a few here internally within our office and externally with our membership, and on special subjects. She is deeply involved with those. She also assists with ASTHO's technical assistance to the U.S. territories and freely associated states. Maggie and I just got back from the Republic of Palau, where she's conducting some return on investment analysis. Ms. Carlin received an MPH from the University of North Carolina at Chapel Hill in health behavior and health education. Prior to joining ASTHO, she completed a research internship with the National Association of Community Health Centers and has served in various roles in safety net healthcare administration. So thank you, Maggie, for joining us today. With that, I'll turn it over to you.
Great. Thank you so much, Carl. So hello, everyone. As Carl mentioned today, I'm going to talk just a bit about a survey that ASTHO conducted last winter of health agency chief financial officers. So first, just an overview of what I'll cover here. For those who aren't familiar, I will give another just brief overview of the survey in addition to what Carl mentioned, and a little bit about its inception. And then following that, I'll talk a bit about the methods and then dive into our findings. So for background, Carl talked a bit about this, but as some of you know, in order to meet the CFO Network's strategic map priority of collaboration and also to address the group's interest in innovative public health financing mechanisms, ASTHO hosted an innovative financing roundtable, and that was in April of 2015. So the roundtable convened a small group of chief financial officers and also senior deputies to discuss the feasibility of taking on various innovative financing approaches that are of particular importance to public health. So after much discussion there, that group prioritized community benefit for further development. So the first action step from that was then to determine the extent to which public health is already involved in both community health needs assessments and also community benefit activities and decisions, and then also to identify lessons learned and best practices. So with the support of CDC, ASTHO conducted the Community Benefit Survey to collect data on states' activities related to community benefit. So as I mentioned, this survey was fielded in the winter of 2016, so just earlier this year, and the instrument itself was a 10-item online survey with both quantitative and then also open-ended questions. And the survey consisted of two major sections. So one was on community health needs assessments and one on community benefit more broadly. So the survey was distributed to all of ASTHO's 59 member agencies. So that's those including those in the states, DC, the U.S. territories, and then also the U.S. freely associated states. And the survey was sent to health agency CFOs who were invited then to also gather input from others within their health agency, such as the senior deputy or other agency staff as needed, who might have some input on their work with community benefit. So of those 59 jurisdictions, 34 completed the survey for a response rate of 57.6%. And before I go on, I just want to take a moment to acknowledge and thank those who are on the webinar who completed the survey. Your input was absolutely crucial to ensuring that our data was comprehensive. So thank you. We recognize the time required to complete this, and we're really grateful. So next, I will dive into the results. So in looking at that first section on community health needs assessments, respondents were first asked whether their health agency had been contacted by a hospital system, or a state hospital association to help in the development of a community health needs assessment. And 67.6% of respondents said yes to this question. But in addition, 17.6% selected other, and they clarified mostly that the needs assessment process in their jurisdiction is actually coordinated by another body. So it's not conducted by the hospital or a hospital system, but rather another body such as a local or regional health department, the state health agency itself, or in some cases another institution such as a university. So this graph here shows the responses from agencies that are either planning to undertake or have already been involved in these activities listed, and that's in the last 5 years. So those activities were providing data for use in community health needs assessments, and we found that 97% of respondents had either planned to do that or had been involved in doing that. 82.4% were involved in providing assessment tools that were used in community health needs assessments. 76% were involved in identifying partners or key stakeholders to be included in those needs assessments, and 66.7% were involved in setting priorities based on needs assessment results. And respondents were also asked to share any additional information they felt was important regarding their public health agency's involvement in community health needs assessments. So we analyzed those qualitative responses, and we found a few major themes. So many respondents mentioned a particular needs assessment partner in their state, such as a local or tribal health department, a hospital association, a community-based organization, or a community coalition, and also primary care associations. And additionally, many comments indicated from what level the needs assessment process is led in their jurisdiction. So in this case, just state and local coordination were identified. And lastly, a number of comments also specified the health agency's involvement in the needs assessment process specifically. So that included comments about things like the health agency actively encouraging collaboration, participating in health data requests, providing funding or support, and sometimes developing either an evaluation toolkit or indicators. Also, some states were involved in participating in health data training or providing other technical assistance. So diving into the results on the community benefit section of the survey, health agencies were asked to indicate the status of certain agreements as they pertain to community benefit activities within their jurisdiction or agency. And we found that few respondents had rules or formal agreements in place. So specifically, 21.2% of respondents had implemented or were planning to implement regulations or guidelines specifying how community benefit activities were implemented and enforced. And then just 9.4% were planning to implement legally binding agreements between hospitals, public health agencies, and other partners. And lastly, we found that 9.1% had implemented legislation specifying how community benefit priorities are established or they were planning to do so. However, 60% of respondents stated that they have implemented or are planning to implement alignment of community benefit activities with national or state public health frameworks. So this includes accreditation standards, foundational services, and the State Innovation Model, or SIM, Population Health Plan. And others that were mentioned among those who noted a specific framework were also the Public Health Accreditation Board Standards and Healthy People 2020. And we also found that community-based organizations, local health departments, and state and territorial health agencies received full, partial, or in-kind direct community benefit dollars or resources in the past 5 years from the community benefit provision. So for community-based organizations specifically, breaking that down a bit, respondents indicated either that the resource they received, whether that was in-kind, full, or partial, it either replaced those resources that were formerly distributed by their state or territorial health agency, or they augmented funds that were awarded by that agency, or that resources were distributed for priorities that were defined by the state health agency. So here on this next slide, respondents indicated the stakeholders with which their health agency has engaged with respect to community benefit. And we found that nearly 93% have engaged with hospital and or hospital system partners. So in looking at the qualitative data for this question, respondents indicated primary care associations, hospital associations, and hospitals for this particular question. 75% have engaged with state-level partners, so that includes state hospital associations, university systems in some cases, other state agencies. Some that were mentioned included the Attorney General, their State Office of Rural Health and Primary Care, the State Medicaid Office, the legislature, and also in one state, a Department of Mental Health. Other state-level partners included committees and coalitions, and then other nonprofits. 53.6% were engaged with local level partners on community benefit. So that included local health departments, but also community health centers or federally qualified health centers, and also others, including schools, emergency responders, and banks. About a third of respondents were engaged with community-based organizations on community benefit activities, and that included, one specified included wellness coalitions and also legal aid. And then lastly, the smallest group was that about 20% were involved with national or federal level partners. And that included governmental partners such as HRSA and the Federal Office of Rural Health Policy, and then also non-governmental partners, including NACCHO, Hilltop, and the Public Health Accreditation Board. And here on this next slide, respondents were asked to indicate from which sources their agency receives information about the amount of community benefit dollars or resources that are being invested each year in their jurisdiction. So the most common response was that this data comes from publicly available reports provided by hospitals, but some others also received information from interviews or informal conversations with nonprofit hospital staff, surveys of nonprofit hospitals, and then also non-public reports that were shared with the health agency by the hospital. So when asked about best practices and lessons learned, many respondents mentioned a partnership, including specific entities and also collaborative activities. Some also mentioned alignment with an accreditation requirement. Others mentioned a specific best practice, such as framing community benefit as an investment. They suggested having a designated community benefit staff person in health systems to lead greater public health integration. Some suggested that the coordination be housed in health agencies, and others suggested that a portion of Certificate of Needs funds be prioritized for community work. There was also mention of particular challenges related to community benefit, including that it can be difficult to determine the funding source of the services that are provided, and also that the IRS community benefit reporting requirement may not actually reflect total community health spending. So with that, in terms of next steps, Carl mentioned that the survey will help inform the development of a white paper for state and territorial health agencies interested in taking on community benefit activities, and this will be available shortly. And I just want to say thank you again to those who completed the survey. And now we'll open it up to questions. So what questions can I answer about the survey or the results that I went through here?
The conference has been unmuted.
This is Carl. I found that to be a wealth of information and very thought-provoking. I found it particularly interesting that you all reported alignment with public health frameworks about 2/3 of the time. So that's very promising, because I think usually we think that public health is not widely utilized as a good resource or an active partner in these community health needs assessment endeavors or setting priorities from them to provide community benefits. And then some of the promising practices I thought were very enlightening. I'd be interested in hearing questions, clarifications that folks would like to raise with Maggie concerning the survey and its findings. I know we have state legislative liaisons on the phones, some senior deputies, and of course, several chief financial officers.
This is Hughes Melton, Chief Deputy in Virginia. Quick question for you, Ms. Carlin. So did you collect any information on the nature of the health district that was responding to the survey, so rural versus urban, that sort of thing, and was there an opportunity to do any sub-analysis to see if there's a difference in some of the percentages based off of the nature of the area that's doing the assessment?
That's a great question. So we did offer respondents the opportunity to indicate their jurisdiction. So not all did, but we do, for many respondents, know their jurisdiction. And we also have from other ASTHO surveys, such as our profile survey, we have information on geographic classification, such as rural, urban, et cetera. So what we could do from that is kind of take a look at which jurisdictions responded and cross-check that with some of these questions. Are there any in particular that stand out to you as ones that might have a difference by geography?
Yeah, I guess I was surprised on the slide where it talked about what percentage reached out to local stakeholders, community stakeholders, that those percentages seem low to me. I would think that, I don't know that that would necessarily be a rural-urban sort of dynamic, but I certainly know that, I just met this today over lunch with one of our local health districts, and they're very engaged with local community stakeholders. I would have suspected that they would have answered yes to that. But no, other than that, I don't think that there are definitely some specific areas where there might be a difference in urban versus rural.
Okay, well that's helpful, yeah. So we can certainly dig a little bit deeper into that, and also into the question that you pointed out about stakeholder engagement. I would say that, keep in mind that a lot of jurisdictions indicated who was coordinating this process and these activities in their jurisdiction, and that may have a little bit of an impact on who might be taking on the engagement process and reaching out. So if it's not coordinated at the state level, then that might change things up a little bit. But that's something also that we could dig into a little bit more in the data. Thanks for that question.
Thanks.
This is Abby from Minnesota, the CFO here. And I had a question. I was surprised at the high percentage of states who have laws that, set priorities or direct priorities. Did you collect any examples of what those laws are as part of the survey?
We did. We asked, as an optional question, we asked respondents to indicate the law if they had it, and some did. So that's something that we could certainly pull out into the report, is to specify what those are if you wanted to look further at the language used or which states have those.
That would be great. Thanks.
Sure. Thanks for the question.
Other questions, comments, thoughts?
Well, hey, Carl, this is Arturo, New Jersey, and Maggie. I was going to ask the question, your thoughts about that 60% or near two-thirds of the collaboration with public health agencies. And I was going to ask, how surprised or are you about that or not? It sounds like you're pleasantly surprised. Based on this, and maybe, I don't know if you're able to mine some of the data enough to understand about saying more about what makes some of those partnerships more successful than others, and what makes some of the partnerships even go. I don't know if this survey can get to that, or maybe you can speculate on that, and what the value of our hospital partners find in partnering with the public health agencies to do this. So I was pleasantly surprised too, but I guess the question I'm asking is, how do we get that a little bit, bump it up to 80% next time?
Yeah, I think that's a great question. And the basic answer is that no, the survey doesn't really get into that and didn't ask quite specific enough questions to get there. But I think you're right that that's one of the findings we can pull out and decide that we want to pursue a little bit more in the future, to dig in and find out more specifically for those who do have high levels of engagement, what are their best practices and lessons learned, and how are they making those partnerships run smoothly. I don't know if you have anything else to add, Carl, what might make those successful.
Yeah, and of course we have, I think we have a wealth of information on the phone. Dr. Haft will be talking about his efforts in Maryland, but quite frankly, I'd be interested in hearing from those represented on the phone who have begun a dialogue, have an active partnership, if they have anything to contribute to this about how they got that started, what were the initiating steps. I guess I'd leave it at that. I'd open it up and see if there's any knowledge in the room about that. For instance, not to pick on you, Abby, but I know that you've had some back and forth in your state working on this issue. What have been some of the things that led to a better dialogue? What are some of the lessons learned?
Well, unfortunately, you are putting me on the spot because I'm probably not the best person here to answer that, since much of it was before my time at the department. But, I think the biggest lesson learned is that where we do want to try to align the priorities that the community benefit spenders, for lack of a better term, are spending their money on, and where we as sort of public health officials would suggest they do, that really needs to be a partnership. And one of the challenges we had is when we tried to advance that at a time when that partnership wasn't as strong.
Right.
It ultimately undermined the law change that we had sought to sort of require that alignment.
Right. That's really what I was hoping you'd kind of talk through, Abby. I think one of the things when we convened the CFOs and senior deputies in Atlanta, Georgia, a year back, was that it's very important for public health not to kind of go from 0 to 60 and start talking about money. That instead we need to do some background work on enlightening folks on the wealth of data we have, which oftentimes are used in these community health needs assessment, even if public health is not an active partner, and the expertise we have in knowing our communities and working with our communities, and start the dialogue there, start sharing our priorities, and start the dialogue on those terms about what we can bring, the wealth of experience, resources, knowledge we can bring, so that we can start building that partnership at that level before we start talking about common priorities, common frameworks, and maybe even some funding decisions that could be made jointly. So I don't know if others have insights. That's one thing I gleaned out of the roundtable, for instance. Any other insights into this question that could enlighten Arturo's query to the group?
This is Sylvia Pirani in New York. So we have a statewide public health improvement plan known as a prevention agenda, and we put out guidance to the hospitals and the local health departments in the state for how they're supposed to, every 3 years they do their local community health improvement plan, including the community health needs assessment, which would help hospitals meet their federal requirements. And we, in the guidance that we give them, ask them to pick two priorities from the state's prevention agenda, including one that addresses the disparity. And we've asked them this most recent cycle to make sure that they're aligned, that their community benefit investments are aligned with those priorities, and that they're investing in evidence-based interventions associated with them. And we're just looking at some data now with one of our partners. I mean, one of the things that hospitals complain a lot about is that they don't really pay attention to how they do their community benefit reporting, and it doesn't fully reflect everything they're investing in, so that we shouldn't be using it as the sole source of information for what they're investing in. So part of it is just a reporting, issue.
Mm-hmm.
Thanks, Sylvia. Yep, I know about the work that you do, and I may be contacting you, but appreciate that.
Yeah, that'd be great.
Yep, thank you.
I'd love to chat. Yep.
And of course, I think many of us are envious of New York. With your enabling legislation, you're really an active partner, maybe even a driving partner at the table. So learning lessons from that about how we can start that dialogue and move towards that position is excellent. Glad you joined us today. All right, any other questions for Maggie? Well, I think this is a good segue, because now we're going to hear from Dr. Howard Haft, who is the Deputy Secretary for Public Health at the Maryland Department of Health and Mental Hygiene. And I think he's going to walk us through some of the efforts in his state, take a deeper dive into some good practices there, and will help develop this conversation a little more, and maybe provide us some background and context on that as well. He comes with a wealth of experience, Dr. Haft. He was the founder and the chief medical officer of the ConMed Healthcare Management, a publicly traded company providing a full complement of healthcare services to inmates in county detention centers nationally. He served as the president of the Maryland Healthcare, a multi-specialty clinic in Southern Maryland, and as president of the Maryland Foundation for Quality Healthcare, and as medical director of Health Partners, Inc., a free clinic serving Charles County, Maryland. Dr. Haft served as the medical director of Shaw Associates, a multi-specialty private group practice with over 100 providers in 5 Maryland counties. Dr. Haft has also served as the chief executive officer of the Ellis Medical Group, a 250-provider multi-specialty hospital and community-based practice in New York. So I think if anyone can speak the language of hospitals, it would be Dr. Haft. And now, as I said, he is a Deputy Secretary for Public Health at the Maryland Department of Health and Mental Hygiene. So thank you so much for joining us today, Dr. Haft. I look forward to hearing your presentation.
Thank you, Carl. It's a pleasure to have an opportunity to speak about community benefit. And I want to give a bit of an apology to begin with. If I'm overshadowed by a loud noise, I'm sitting here in Baltimore, also known as Charm City, and it happens to be Fleet Week this week in Charm City, where the USS Zumwalt will be christened by the President, and we have flying overhead at about 5-minute intervals the Blue Angels, which is a great sight to see, but it's a little noisy because it comes right over the top of the building. So that's just an apology if I get overshadowed for a little bit. But I did want to thank Maggie for the excellent work that she did in the survey, and I think it really does represent broadly two things. One, the engagement levels at various ways in which public health and community benefits and hospitals seem to be coming together at various levels across the country. But it also points to the great diversity in which those things are happening. And I wanted to use, one of the reasons why I'm eager to speak to you today is I think Maryland, because of its uniqueness, represents perhaps a window into one of the future paths to really align the needs of public health and hospitals together so that they can work hand in glove to create healthier populations. So we're going to go on to the next slide. Maryland is one of those states that enacted a law that governs the definition of community benefits. The Maryland law defines a community benefit as an activity that is intended to address community needs and priorities, primarily through disease prevention and improvement of health status, including these bulleted items: health services provided to vulnerable and underserved populations, financial or in-kind support of public health programs, donations of funds and property, health care cost containment activities, health education, this is an important piece, screening and prevention services. And these were all defined in what we call Health General and the Maryland Annotated Code. So those things are really not in themselves, I think, particularly unique. They really describe a broad brushstroke back in 2001 of the various things that hospitals could do to fit into the rubric as it was described in the TACT Acts for IRS to preserve their 501c3 status. The world changed, as you know. They moved on after the Affordable Care Act and further defined what things must be done in the community benefit, which included, as we've just spoken about, the community health needs assessments that hospitals must do or undergo a fine on every third-year basis. Next slide. So in Maryland, here's what this looked like. And I want to say that this is 2014 state reporting, which really kind of reflects Maryland as it existed in one of its unique aspects. So as I said previously, there was a law that defined that there were regulations that the state had to, all the hospitals in the state had to abide by. But Maryland was the last remaining all-payer state, which is, if you're not familiar with it, I'll spend just a moment on that. It means that all hospitals in the state have their hospital rates controlled by what is called the Health Services Cost Review Commission. And those rates are the same for all payers, Medicare, Medicaid, commercial payers. And those rates are set for each and every hospital. And it's was previously set based on fundamentally what the needs of the hospital were. It was set at a time 35 or 36 years ago when the rates for Maryland hospitals were far above the national average. And because of the introduction of this rate-setting commission, it drove the rates down for each hospital down to below the national average. So it was a great success in terms of setting rates for each individual service that were below the national average. It didn't do anything, however, to control the volume, and that'll be a second part of the story. But in this framework that we see here, we see what Maryland did while they were still largely a state that had the rates controlled by the state, and a law that spoke to how they would govern community and report community benefits. In the rate setting ability that the Health Services Cost Review Commission had, they also were able to carve into those rates an amount that would cover uncompensated care, an amount which is basically charity care, an amount that would cover the DME, the direct medical education costs that hospitals had, that were teaching hospitals, and a number of other costs. So there was kind of a unique setting in that you really couldn't double count that. If you were already paid in rates for charity care, you couldn't really completely say, well, I'm giving charity care, therefore that's my community benefit. So there was a piece that was carved out of that, and a very fine distinction done that says what was the total amount of after charity care, after what was allocated in the rate. So if you see on this, we really would look to the last column of this chart to see what the real contributions after what was already given to the hospitals based on the rate setting commission. And you can see from that a large chunk of it was not charity care, because that was already cared for or accounted for in the rates, but a large portion was in health professions education. That was both for nurses and for doctors, and mission-driven health services. And mission-driven health services are basically subsidized services, which is kind of the delta between what you would expect to get if you were negotiating if you're getting direct Medicare or other kinds of services, and what you actually get otherwise. And that was the biggest chunk. There were some things here, 11% or 12% community health services, some in unreimbursed Medicaid cost, and then a few other things in terms of community building and financial contributions. But still, the largest were mission-driven health services, and I think we saw here we see in a lot of other places, a lot of the services that were provided as community benefit, and what I've seen in this state and other states that I've worked in, really are things that in many ways still serve the purpose of the hospital, that is doing educational programs in the community about hip replacements or bypass or bariatric surgeries, or things that although they were educating the community, also very much served the mission-driven purposes of the hospital, so that they served at least two purposes. But were not, in their purest sense, population health defined. And even though in our state and in others there were community health needs assessments done, we found when we looked at those that, and even in our reports, that the investments did not always match up one-to-one with what was defined as a community health needs assessment. When that didn't happen, we asked hospitals to say why that didn't happen, and very often there were financial or other reasons why that didn't happen. But the point is that it didn't consistently happen. Let's go on to the next slide. So, as I said, Maryland was an all-payer waiver state for many years. It was actually a federal statute that allowed us to do that. But after 36 years of that, there was a rise in the per capita cost for patients, and that in the hospital side and the Part A side, and Medicare certainly was attentive to that and said, even though your rates might be low, your volumes are high, and the net is that your per capita cost is quite significantly higher than other states. Some of our rural hospitals entered into an experimental model. It was called the Total Patient Revenue Model, which was basically a globally budgeted model, which actually had some early success. And then in 2014, a new waiver was gained with Medicare that brought all of the hospitals in the state into global budgets. Again, this is unique, and it was done under the all-payer model. But all hospitals no longer are paid on a volume basis. They're paid on a global budget. global budgets have a chilling effect on volume. What they really say to hospitals is that it is no longer in your best interest to have high volumes because you'll have greater utilization of resources, and it's best to only take that volume which is the most advantageous, the most needy volume, serving the needs of the community, and not try and generate excess volume. So the hospitals have all undergone kind of a religious conversion, and they broadly stated, the Maryland Hospital Association broadly stated that our keen interest now is in the health of the populations that we serve, and it's to create healthier populations and to reduce avoidable utilization. And the second phase of this waiver not only brings the hospitals into global budgets, but aligns the total cost of care, both on the ambulatory side and on the hospital side, so both Part B and Part A, into the same kind of, if not global budget, the same kind of value-based payment system. This is certainly aligned with what's going on at another level with Medicare and the release today of the final rule of MACRA, which says that all providers will be on some value-based or advanced alternative payment model by beginning now and concluding through 2019. And Medicare, moreover, put on their website that, moreover, the Maryland system may serve as a model for other states interested in developing an all-payer payment model system, because this really does work with them. But really, how this now reflects on, and we can go on to the next slide, on the provision of community benefits, is now hospitals are really paying very keen attention to creating healthier communities, because it's clearly in their financial best interest to do that also. And they've invested hospital dollars in not only in finding greater alignment with kind of our succession of community health needs assessments, how that informs our state health improvement plan, but have included that in how it informs an overall population health plan for the state, and defining those areas of population health that the hospitals are focused on to be in alignment with public health, to make those fundamental improvements, which are not just things that are serving to volume, but things that are serving to creating healthier communities. So this next slide is just really kind of an overview. It shows on the old waiver, it was a per inpatient admission hospital payment system. On the new waiver, it's an all-payer, capitated total hospital payment and quality model, which is, in my limited view, really nirvana when it comes to be able to align the incentives of hospitals and public health, and in the next wave of this also of the community providers. There are some other provisions in the new model, which included maintaining the ceiling for growth at a very limited level and returning dollars to Medicare over a period of 5 years. And also, part of the waiver was to have patient and population-centered measures to promote care improvement. Go on to the next slide. So this is the transformation process and progression. In 2014 and 2015, our hospitals all became globally budgeted in the all-payer model. In 2016, which we've begun now, and through 2018, we're establishing financial alignment between hospitals and also community providers. And in 2019 and beyond, the all-payer model goes to total cost of care overall, which aligns all the incentives for all the providers in the state. And how this works with population health, as I said, it started with the state health improvement plan or local health improvement coalitions, having them inform this waiver. And now in 2016 and 2018, we're building partnerships and infrastructure, including regional care management entities, regional coordination entities with partnerships with multiple non-hospital and provider entities providing kind of wraparound services and dealing with social determinants, and then moving 2019 and beyond into sustainable population health models. And these are focused on the needs of the community, supporting social needs, and identifying, particularly in the early stages, high-risk individuals, but moving on to address individuals at all levels in the healthcare pyramid. So I think we're fortunate. And I would say sometimes it's better to be lucky than smart. And I feel particularly lucky to be in Maryland at a time when these forces seem to be in play, and we can really now begin to leverage those community benefit dollars. Go on to the next slide if you wouldn't mind. So Ben Holstrom, just this last week, was announced as a Nobel laureate in economics. And he won that based on work that he did in the 70s and 80s on contracts, which seems a little curious. But really what he did is really seminal work in contracts, and said that for any contract, whether it's a contract, it's a business contract or any other kind of contract, if it's built on a principle that everyone agrees on and the incentives are aligned, that contract will be successful. And if it's not built on principles or it has misaligned incentives, those contracts are largely inclined to become non-functional and unsuccessful. And he showed this in many businesses, both publicly traded and private businesses, et cetera. But I think it also applies broadly to what we do in the state. And I think we are the work that we need to do to make population health work across the board is to align the incentives so that providers have an incentive and that hospitals have an incentive and population health has an incentive to, and public health has the same incentives, both financial and by principle, to create healthier communities. I think when we can get there, all of the hard work that we have to do will be made much easier, as it is being made for me in this very fortunate place right now. So with that, I'll close and open up to questions.
Wow, thank you so much, Dr. Haft. You are in Nevada. That was really insightful, and I like the way, I believe this was undertaken through the Waiver Demonstration Authority, expanded, and then we're currently in a transition period. I wasn't really realizing when I talked with you on the other day on the phone that it's still being built as we're seeing this through, so we really appreciate you filling us in on that. We do have about 8-9 minutes for questions. So now is your chance to pose them to Dr. Haft or Ms. Carlin.
Dr. Haft, this is Carter Kimball, Director of Policy in Oklahoma. I'm wondering, when you mentioned your hospitals moving under global budgets, you mentioned how other community providers were kind of linked in on wraparound services. Are they compensated separately, or is it accounted within that global budget and then the hospital somehow funnels that down to them, or how does that interaction look?
Yeah, so right now there are a number of programs in development and some that are actually in play. The ones that are in play is that as the global budgets came about, the hospitals recognized their need to improve community health to reduce unnecessary utilization, and they spawned, I believe it's 11 regional collaboratives. And those regional collaboratives were given grants out of hospital dollars under the waiver to create essentially healthier communities, particularly to focus on disparities, because I think as in many other places, a lot of the utilization for hospitals finds its roots in healthcare disparities. So they were very highly incentivized to establish these regional organizations in places where disparities occurred, and then to be creative in terms of what kind of tools they needed to use to deal with disparities. And some of these were transportation tools, some of them were nutritional tools, some of them were educational tools, some of them were spawning community providers where there were none. They were given a kind of a broad license to be able to do that, and as both as startup funding, but then also as sustainable in models, and then sustainable funding in those that were successful. But moreover, the hospitals have been working with CMMI to create funding mechanisms for providers that would, in the community, particularly primary care providers, that would begin to align their incentives along population health improvement, so that they would be establish advanced alternative payment models under MACRA that would align with the hospitals, and will even be potentially able to, under amendments that the hospitals have in their waivers, to have additional funding for those providers related to the high utilization patients. But they are, as I would say, it's 1,000 points of light. A lot of innovative programs going on, but all with those same aligned incentives to create healthier communities, and not as the system was designed before, to create greater volume. Before, the system was highly incentivized to have more volume. The more volume, the more revenue. Now it's changed and pivoted 180 degrees, and it's highly incentivized to create healthier communities. So all of these models that are coming up, both those that are experimental and those that will be carved into the fabric and framework of the delivery system, are all aligned with those principles now.
Very interesting, very interesting. Other questions? We have one chat announcement here from Emily Moore. Do you want to just announce that to the group, Emily?
Hello, everyone. My name is Emily Moore. I'm a Senior Analyst in Health Systems Transformation here at ASTHO, and I'm really glad that you brought up MACRA, because that's a really exciting time, especially as we're considering how health systems and public health are working together. The announcement is that our team is developing a fact sheet to help state health officials and their staff understand the MACRA changes, including the new regs that were released today. So it wasn't so much an announcement as a plug for stay tuned for the future of resources.
Great.
Very good. Yeah, thanks, Emily. And the Science and Strategy team will also be sending you shortly the posting, probably on our SharePoint site, not only this presentation today, so you can view it again or circulate it to others, but some of the other resources, the white paper that's under development, and a report that Maggie helped author in terms of Maggie was the primary author, I guess, in terms of the community benefit survey. Other questions before we wrap it up for today? Thoughts, comments? Okay. Well, again, thank you so much for your participation, your active participation in the survey, your active participation today. I see a lot of familiar names up there in terms of participants, some of them overseas. I see our USVI representative is on the phone, Tiesha Phillips-Dorset, and others from across the country. Joe Lewis all the way in Alaska, so we cover quite a few time zones right there. Thank you so much for participating today. As you exit, please do take a few minutes to fill out the survey, which will be shown here. And we appreciate your participation. Look forward to future engagement. Thanks very much. Have a great weekend.
Thank you. Bye-bye.
Thank you.